Stop for a second. I want you to think about what you did this morning. Maybe you took a blood pressure pill with your coffee. Maybe you grabbed an ibuprofen for a sore knee before heading out. Maybe you popped an antacid after breakfast. If you are over 40 and you did any of those things this week, what I am about to share with you matters more than you might expect because there is something happening inside your body right now quietly, without any warning signs, that most people in your position are never told about. And over the next 10 to 15 years, it has the potential to affect your heart, your energy, your memory, and your kidney health in ways that almost everyone, including most doctors, will look at and say, well, that is just part of getting older. It is not always. And that distinction could genuinely change the next chapter of your life. I am Dr. Megan Foster. I spent more than 2 decades in surgical and cardiovascular practice, and I have personally prescribed every single medication we are going to talk about today. So when I tell you that medications save lives, I mean it completely. I have seen them prevent heart attacks, reverse heart failure, stop strokes before they happened. This is not a video about distrusting your doctor or throwing out your prescriptions. This is about something more specific. It is about what happens when medications that were the right choice at 55 are still sitting in your medicine cabinet at the same dose with no real review at 68. Because the body that is taking those medications is not the same body they were prescribed for. And that gap between who you were when the prescription was written and who you are now is where a lot of quiet, preventable problems start. Let me tell you what I have seen happen more times than I can count. A patient comes in, usually in their late 60s or early 70s. They have been on the same 4 or 5 medications for 7, 8, sometimes 10 years, and they sit down and tell me they have been feeling off, tired in a way that sleep does not fix, a little unsteady on their feet, muscles that feel weak. Their blood pressure has been fluctuating more than usual, and they say to me, I guess this is just what getting old feels like. I look at their chart. I look at everything they are taking together, not each prescription in isolation, but all of it as one complete picture. And nearly every time I find combinations and doses that were set years ago and have never been reassessed. Not because anyone was careless, just because appointments are short, prescriptions get refilled, and life moves on. But the body keeps changing, and the medications do not automatically adjust to keep up. Here is what is happening on a biological level, because I think understanding this clearly is what makes everything else in this video click. When you are in your 40s, your liver is processing medications at close to full speed. Your kidneys are filtering your blood efficiently. The minerals in your body, things like magnesium, potassium, and calcium, stay relatively balanced. Your heart rhythm is resilient. Your muscles bounce back from strain. Medications do what they are supposed to do and clear out of your system on schedule. By your mid to late 60s, each of those systems has slowed down. Your liver takes longer to break down medications, so they stay in your system for more hours than they used to. Your kidneys filter more slowly, so the byproducts of those medications do not get cleared out as quickly. What that means practically is that a dose calibrated for a younger body may now be producing a stronger effect than intended, simply because your body cannot clear it as fast. The mineral balance that once held steady becomes easier to disrupt. Your heart becomes more sensitive to medications that affect its rhythm or rate. None of this is dramatic. It does not feel like anything obvious. It is a slow shift. And the symptoms it produces, fatigue, brain fog, low energy, balance issues, these are the exact same symptoms that people attribute to aging, which is why they so often go unaddressed for years. Researchers who study this have found that adults over 65 who take 5 or more medications at the same time have a significantly higher risk of falls, kidney problems, cognitive changes, and cardiovascular complications than people taking fewer drugs. And the critical point is that many of these complications are not caused by any single medication being wrong. They are caused by the combination running for years in a body that is processing everything differently differently than it did when those prescriptions were first written. This is not rare. This is one of the most common causes of preventable health decline in older adults, and yet it is rarely discussed openly because the conversations about it require time that most appointments do not have. So let me give you that time right now. Let me walk you through the 5 most common medication categories that deserve real, honest, periodic review after 60. I am going to explain what each one does, what can go wrong with long-term use in an aging body, and what you specifically should be asking about at your next appointment. Before I do, I put together a practical guide for people in exactly this situation. It covers the lab markers that matter most after 60, the questions to bring to your annual checkup, and lifestyle approaches that have real research behind them for supporting heart and vascular health. It is linked in the description. Now let me get into the medications. The first category is statins, cholesterol-lowering medications. You might be taking atorvastatin or simvastatin. And I want to be direct right away. Statins have strong, well-documented benefits for people who have already had a heart attack, who have been diagnosed with coronary artery disease, or who have a very high calculated risk of a cardiovascular event. The evidence here is real. I am not suggesting anyone stop their statin. What I am telling you is that statins have an effect beyond cholesterol that your doctor may have never mentioned, and it is one worth knowing about. Statins work by blocking a pathway in the liver that produces cholesterol. But that same pathway also produces something called CoQ10. If you have not heard of CoQ10, think of it this way. Every single cell in your body needs to convert fuel into usable energy, and CoQ10 is a critical part of that conversion process. Your heart muscle cells, which work nonstop every minute of every day, are among the highest consumers of CoQ10 in your body. When you block that production pathway with a statin, CoQ10 levels can drop over time. And when they drop significantly, some people start to feel it. They describe a kind of fatigue that is different from being tired. It feels more like a heaviness, a lack of drive, a body that just does not have the same spark it used to. Some people notice muscle aches or weakness that seems to have no explanation. The medical literature on the link between statin use and CoQ10 reduction is substantial. But because CoQ10 testing is not part of standard monitoring, and because these symptoms are so easy to write off as aging, most people on long-term statins are never evaluated for it. There is also a connection between long-term statin use and blood sugar levels. Multiple large studies have found that long-term statin use modestly increases the risk of developing type 2 diabetes. For someone at high cardiovascular risk, that trade-off is generally considered worth it. But it does mean that if you have been on a statin for several years, your doctor should be tracking your blood sugar regularly, not just your cholesterol. And there is one more nuance that I think is particularly worth knowing. The strongest evidence for statins is in what doctors call secondary prevention, meaning people who have already had a cardiovascular event. For people over 75 who have never had a heart attack and do not have diagnosed heart disease, the research on whether statins provide the same level of benefit is actually less clear than most patients assume. It is a perfectly reasonable question to raise with your physician if that description fits you. Now let's talk about something that probably does not feel like a medication to most people: ibuprofen, naproxen, the over-the-counter pain relievers you grab when your back flares up or your knees ache after a long day. These are NSAIDs, and they are used constantly by people over 60 because joint pain and arthritis are genuinely difficult to live with, and these drugs genuinely work. For short-term use in younger, healthy adults, the risks are manageable. But in people over 60, regular use of these medications carries consequences that are seriously underappreciated. Partly because they are available without a prescription, partly because nobody has ever sat down and explained exactly what is happening inside the body when you take them repeatedly over months or years. Here is the key thing to understand. These drugs reduce inflammation by blocking certain proteins in the body. That is their intended effect. But those same proteins also protect the lining of your stomach, help regulate fluid balance in your body, and play a role in maintaining healthy blood flow to your kidneys. When you block them repeatedly, you reduce those protections at the same time. For your kidneys specifically, the problem is this: your kidneys depend on adequate blood flow to filter waste from your blood. NSAIDs reduce that blood flow. In a younger person, this is brief and the kidneys recover quickly after each dose. But for someone in their 60s or 70s whose kidney function is already working at reduced capacity, which is very common and often completely unknown until it shows up on a lab test, repeated reductions in kidney blood flow can gradually push function lower over months and years. Silent, no symptoms, just a quiet decline. NSAIDs also raise blood pressure directly, and here is something that surprises a lot of people. If you are on a blood pressure medication, NSAIDs can make it work less effectively. ACE inhibitors and ARBs, two very commonly prescribed blood pressure drug classes, have their effectiveness meaningfully blunted by regular NSAID use. So while you think you are managing two problems, your blood pressure and your joint pain, one of your treatments may actively be working against the other. And if you are on a blood thinner, taking NSAIDs at the same time significantly raises your risk of serious bleeding. This is a combination that genuinely requires medical guidance. I am not saying never take a pain reliever. I am saying that if you are using ibuprofen or naproxen multiple times a week, week after week, it deserves an honest conversation with your doctor. There are alternatives worth exploring, and your kidneys and blood pressure deserve to be part of that conversation. The third category is acid blocking medications. You probably know these as heartburn pills. The most common ones are omeprazole, pantoprazole, and lansoprazole. They were designed for short-term treatment of ulcers, severe acid reflux, and esophageal irritation. They work well. For the right condition in the short term, they are genuinely helpful, but something that happens frequently is that people start them, they feel better, and then they just keep taking them for a year, 3 years, a decade. And because there are no obvious side effects, nobody questions it. The issue is that your stomach acid does more than break down food. It is essential for absorbing certain vitamins and minerals from what you eat. When you suppress acid production for a long period of time, your body starts to fall short on some things that really matter. Magnesium is the big one. Your body needs stomach acid to absorb magnesium properly. When that absorption is disrupted month after month, your magnesium levels can drop, often without any dramatic signal. And magnesium is involved in more than 300 processes in your body. One of the most important is keeping your heart rhythm steady. Low magnesium has a documented link to irregular heartbeats, including a condition called atrial fibrillation, which is an irregular and often rapid heart rate that can increase stroke risk. It also causes muscle cramps, poor sleep, fatigue, and heightened anxiety. Because all of those symptoms are vague and common, most people and most doctors never trace them back to the antacid on the nightstand. Vitamin B12 is another one. Stomach acid helps release B12 from food so the body can absorb it. Suppress that acid for years, and your B12 levels can slowly fall. B12 is essential for healthy nerve function and for making red blood cells. A gradual B12 deficiency can cause memory problems, difficulty concentrating, poor balance, and a persistent tiredness that is easy to explain away as just aging. Left undetected for years, it can cause nerve damage that is not fully reversible. There is also an effect on bone density. Calcium absorption depends partly on stomach acid as well. Less acid over many years means less calcium absorbed from food, which contributes to bone thinning and increases the risk of fractures. In older adults, a serious fracture is not a minor inconvenience. It can be genuinely life-altering. If you have been on an acid blocker for more than a year, it is worth asking your doctor two straightforward questions. First, do I still need this at this dose, or is there an opportunity to try reducing it with some dietary adjustments? Second, have my magnesium and B12 levels been checked recently? The fourth medication category is beta blockers. Common examples include metoprolol and atenolol. These medications work by reducing the effect of adrenaline on your heart. They slow the heart rate and reduce how hard each beat is, which takes pressure off the heart and lowers blood pressure. They are extremely important medications after certain cardiac events, for specific heart rhythm problems, and for some forms of heart failure. I want to be clear about that. But here is what tends to happen over time that often escapes notice. As your nervous system ages, it becomes more sensitive to medications that affect heart rate. A dose of a beta blocker that felt perfectly calibrated at 60 may produce a stronger effect than intended at 70. And when the heart is being slowed down more than it should be, the effects show up throughout the body. You feel heavily fatigued. You get short of breath doing things that used to feel easy. You feel lightheaded when you stand up. When you try to do anything physical, your heart cannot speed up enough to meet the demand because it is being pharmacologically held back. And because none of that announces itself as a medication problem, it gets filed under the category of just getting older. There is a real cycle worth being aware of. When exercise feels too hard because your heart cannot respond normally, people naturally do less of it. And less exercise over months and years has cascading effects on heart health, muscle strength, bone density, metabolism, and mental health. The medication meant to protect the heart can, if the dose is no longer right for where your body is now, make it harder to do the very things your heart needs. If you have made real improvements in your health since starting a beta blocker, better diet, more activity, meaningful weight loss, reduced stress, it is completely reasonable to ask your doctor whether your current dose still matches your current health picture. Never stop or reduce a beta blocker on your own. It has to be tapered gradually under medical supervision because the heart can react strongly to its sudden removal. But starting the conversation is not only reasonable, it is exactly what you should do. The fifth category is blood thinners. Medications like warfarin, rivaroxaban, and apixaban. These are prescribed to prevent blood clots, most commonly in people with a heart rhythm disorder called atrial fibrillation, where the irregular rhythm can allow clots to form in the heart and travel to the brain. They are among the most effective stroke prevention tools in modern medicine. For the right patient, they are truly life-saving. But the risk profile of blood thinners changes as you get older. The main risk is bleeding, and as kidney function declines with age, blood thinners can build up in the body at levels higher than intended. What was a safe and effective dose at 63 may be producing a stronger anticoagulant effect than anyone realizes at 73, simply because the kidneys are no longer clearing the medication at the same rate. This matters enormously in practical terms. A minor fall that leaves a bruise on someone not taking a blood thinner can cause dangerous internal bleeding in someone who is. The balance between preventing clots and avoiding serious bleeds is a precise calculation, and it needs to be recalculated periodically as your body changes. Your fall risk, your current kidney function, and any other medications or supplements you take all affect that calculation. If your kidney function has declined since your blood thinner dose was set, you may be getting more anticoagulation than you need, and more than is safe. Regular kidney function testing should be part of your blood thinner management. And as we talked about earlier, NSAIDs interact with blood thinners in a way that raises bleeding risk significantly. If you are on a blood thinner and you take ibuprofen or naproxen regularly, your doctor needs to know. Now I want to bring all 5 of these together because there is a larger pattern worth seeing clearly. The complications I am describing do not usually start with a crisis. They start with a slow, quiet decline in how someone feels. A little more fatigue each month. A little more difficulty keeping up with things. Blood pressure that seems harder to manage. Lab numbers that are moving in the wrong direction without anyone noticing the trend. And because no single symptom is dramatic, and because every symptom has a ready explanation in the form of just getting older, nothing triggers a reassessment. I have had patients come in after being told for years that their fatigue was just their age. After looking carefully at everything they were taking together, We found that the combination of a statin, a long term antacid, and a blood pressure medication was quietly pulling down their magnesium and CoQ10 levels enough to affect how their heart muscle functioned and how much energy they had day to day. We made careful, medically supervised adjustments. Within a few weeks, multiple patients told me they felt like a different person. I am not saying that a medication review will fix everything for everyone. Sometimes fatigue really is just life, but sometimes it is not. And the only way to know is to actually look. Let me give you something concrete to take with you. A set of 5 questions that will make any medication review conversation genuinely productive. The first question: what is the current reason I am still on this specific medication? Not the reason 5 years ago, the reason today. Has the condition it was treating improved, resolved, or changed in any meaningful way? The second question: are you running the right lab tests to make sure this medication is still working safely in my body right now? For statins, that should include blood sugar and liver markers, not just cholesterol. For antacids used long term, it should include magnesium and B12. For blood thinners, kidney function. For beta blockers, a check on heart rate patterns and energy levels. The third question: when did anyone last look at all of my medications together at the same time, specifically checking for interactions between them, not just looking at each one individually? The fourth question: my kidneys and liver are not working at the same capacity they were at 50. Is my current dosing appropriate for how my body processes medications today? The fifth question: I also take some over the counter products and supplements. Can we go through those together and make sure nothing I am taking on my own is working against what you have prescribed? Bring those questions to a dedicated medication review appointment, not one tacked onto the end of a visit focused on something else. A real appointment set aside specifically for this purpose. That single conversation can do more for your long term health than years of passive refills. I also want to say something about the emotional side of this because I have seen it affect a lot of patients. If a medication was prescribed after something frightening, a heart attack, a stroke scare, a serious diagnosis, it can feel dangerous to question it years later. The medication becomes associated in your mind with being protected, and questioning it feels like voluntarily removing that protection. Some people also worry that asking questions makes them seem like a difficult or non compliant patient. I want to put that to rest completely. Asking questions about your medications is intelligent, it is engaged, it is exactly what good patients do. Research consistently shows that patients who actively participate in their care, who understand what they are taking and why, have fewer preventable complications and better long term outcomes. A doctor who knows their field will welcome these questions. And if you have a doctor who makes you feel dismissed for asking them, that itself is worth addressing. I want to spend a few minutes on lifestyle as well, because it is almost always underused in these conversations. I'm not talking about lifestyle as a replacement for necessary medication. Some conditions require pharmaceutical management and always will. I am talking about lifestyle as something that changes the underlying situation enough that it influences what your medications need to do. For blood pressure, the evidence is clear and strong. Cutting back on sodium, specifically the processed and packaged food sodium that most people barely notice, and increasing potassium from leafy greens, beans, avocados, and fruits can lower blood pressure in meaningful amounts. Regular walking 3 to 5 times a week at a comfortable pace reduces systolic blood pressure by amounts that in some patients are comparable to a low-dose medication. Better sleep, real restorative sleep, has measurable effects on blood pressure regulation. Chronic stress keeps stress hormones elevated, and those hormones directly raise blood pressure. Managing stress is not soft advice. It is cardiovascular medicine. For cholesterol, increasing dietary fiber from oats, beans, lentils, and vegetables reduces LDL cholesterol through a straightforward mechanism. Replacing refined carbohydrates with whole foods and adding healthy fats from olive oil and nuts improves the full cholesterol picture in ways that complement medication, and in some lower-risk people may reduce the need for it. For joint pain, maintaining a healthy weight takes enormous mechanical load off arthritic knees and hips. Less weight equals less pain equals less need for regular pain reliever use. An eating pattern that reduces whole body inflammation, more fish, olive oil, vegetables, and berries, less packaged food and refined sugar reduces the level of inflammatory activity that makes joint pain worse. And targeted physical therapy for specific joints often provides more lasting relief than reaching for a pain pill with none of the kidney or cardiovascular risk. For digestive symptoms, simple behavioral changes such as smaller meals, not eating close to bedtime, avoiding common trigger foods, and slightly elevating the head of your bed can reduce reflux enough that tapering off a long-term antacid becomes a genuine possibility under medical supervision. These changes take effort and consistency. I am not pretending otherwise. But every real improvement in your underlying health is an improvement in the environment your heart and organs are working in. And it changes the conversation with your doctor from managing symptoms to actually shifting the picture. There is another dimension of medication management after 60 that rarely gets discussed, even though it affects how well your medications work every single day. That is how and when you take them. Most people take their medications the same way they always have. They grab whatever's on the counter, swallow it with a sip of water, and move on. But small details about timing, what you take them with, and how much water you drink throughout the day can make a real difference in both effectiveness and how many side effects you experience. Some blood pressure medications actually work better when taken at night rather than in the morning. There is solid research showing that taking certain blood pressure drugs at bedtime reduces cardiovascular risk more than morning dosing for some patients. Blood pressure naturally drops while we sleep, and managing when your medication is most active in the 24-hour cycle affects how well it works with your body's own patterns. This is rarely discussed during prescription refills, but it is worth bringing up with your doctor. Statins are another example where timing matters depending on which one you are on. Shorter acting statins work better when taken in the evening because cholesterol production in the liver tends to be highest overnight. Longer acting statins are more flexible. Knowing which category yours falls into and whether you are taking it in a way that maximizes what it does is a simple conversation worth having. Acid blocking medications are most effective when taken 30 to 60 minutes before a meal, specifically before the largest meal of the day. Many people take them at an arbitrary time or after eating, which reduces their effectiveness significantly. Someone might assume they need a higher dose when really they just need better timing. Hydration is something almost nobody raises in the context of medications, but it matters considerably for older adults. As we age, the sensation of thirst becomes less reliable. You can be meaningfully dehydrated and not feel particularly thirsty. When you are dehydrated, your kidneys do not filter as well, which affects how medications are cleared from your body and can cause levels to build up higher than intended. It also makes side effects like dizziness from blood pressure medications noticeably worse. A simple habit worth building is drinking a full glass of water with every medication and being mindful of consistent hydration through the day. Food interactions deserve a mention too. Most people have heard that grapefruit interacts with certain medications, but fewer understand why. Grapefruit contains compounds that block an enzyme in the gut and liver that breaks down a wide range of drugs. When that enzyme is blocked, medications get absorbed at higher concentrations than prescribed. Statins, certain blood pressure medications, and some heart rhythm drugs all fall into this category. Eating grapefruit regularly while on one of these medications can be the functional equivalent of taking a meaningfully higher dose than your doctor intended. That is worth knowing. Dairy products can interfere with absorption of certain antibiotics and thyroid medications. Taking iron supplements at the same time as other drugs can reduce how well both are absorbed. NSAIDs on an empty stomach increase the risk of stomach irritation. These are practical details that affect day-to-day effectiveness and comfort, and they often get lost between the pharmacy and your kitchen counter. I raise all of this because I want you to leave this video with a real sense that there are many things within your control. The conversations you have with your doctor, the questions you ask, your lifestyle choices, the timing and habits around how you take your medications, how well hydrated you stay, what you eat alongside your medications. These all matter, and every step you take in the right direction makes the whole picture work better for you. Coming back to monitoring one last time, one of the most important shifts in how I think about managing medications in older adults is moving away from the idea that no news is good news. The absence of obvious side effects is not the same as everything being fine. Many of the things that go wrong with long term medications in aging bodies are silent until they are not. And the way you catch them early is systematic, regular monitoring. For a statin, that means periodically checking liver enzymes, blood sugar, and actively asking about muscle symptoms, not just reordering cholesterol numbers. For a long term antacid, a simple blood magnesium level is inexpensive and takes 5 minutes to order. For a blood thinner, kidney function tests should be run at regular intervals because the kidneys determine how much of the drug is actually circulating in your system. For a beta blocker, how you feel during activity, whether you can walk upstairs without getting unreasonably winded, whether your energy has declined, these are clinically meaningful data points. You can drive this. You can bring your full medication list, prescriptions and supplements both, and ask for the monitoring that each one requires. You can ask whether anything on your list is interacting with anything else. You can be the person who brings a level of attention to this that appointments rarely allow time for by preparing before you go in. A word on supplements, because this is an area where people often do not think of themselves as taking something that could have interactions. If you are over 60, there is a reasonable chance you take vitamin D, fish oil, magnesium, CoQ10, or some combination. Most of the time, these are genuinely helpful and the risks are low. But there are things worth knowing. High-dose fish oil has mild blood thinning properties. For most people, that is not an issue, but for someone already on a prescription blood thinner, the combination can push anticoagulation further than intended. Very high doses of vitamin D over a long period can alter how your body handles calcium, which has downstream effects on kidney function and heart rhythm. Magnesium supplements, which are often useful for people on long-term antacids, are generally well tolerated, but can interact with certain antibiotics and with some heart rhythm medications at high doses. None of this means stop your supplements. It means tell your doctor what you are taking, all of it. So the guidance you receive accounts for everything, not just the prescriptions on file. I want to close by coming back to something fundamental. The heart beats approximately 100,000 times a day. It never takes a day off. It adapts to every phase of your life, to stress and calm, to exertion and rest, to the different demands of each decade. It is not fragile, but it is sensitive to its environment. And that environment includes everything you put into your body, how you move, how you sleep, how much you manage your stress, and how carefully the medications and supplements you take are monitored and adjusted as your body changes. You are not at the mercy of your prescriptions. You are not stuck with whatever was decided 5 or 10 years ago. Your health at 65 or 70 or 75 is not a fixed thing. It is still actively shaped by the decisions you make, the conversations you have, and the attention you bring to understanding what is happening in your own body. If there is one thing I want you to walk away with from this video, it is this. Schedule a dedicated medication review in the next 30 days. Bring every medication, every supplement, every over the counter product you take. Ask the 5 questions I gave you. Ask whether your doses make sense for your current kidney and liver function. Ask whether your monitoring is complete. And ask the one question that opens the whole conversation up. Ask your doctor, given where my health is right now, is every medication I am taking still the right choice, at the right dose, for the person I am today? That question is not confrontational. It is not suspicious. It is the most intelligent thing a patient over 60 can bring to a medical appointment. And a good physician will be genuinely glad you asked it. If this video helped you think differently about your medications or your health, subscribe for more conversations like this. Straightforward, honest, evidence based, and designed for people who want to stay actively engaged in their own well being. The longevity guide is in the description if you want a structured framework to help you prepare for that conversation with your doctor. Take good care of yourself. I will see you in the next one. One last thought before you go. Something I hear from patients often is that they feel a bit guilty about not having asked these questions sooner. They have been on their medications for years, quietly accepting the fatigue or the side effects or the vague sense that something was off, and they wonder whether things might have been different if they had spoken up earlier. I want to say clearly, there is nothing to feel guilty about. The way healthcare works does not always create the space for these conversations. Appointments are short. Doctors are managing a lot. Prescriptions get renewed in systems that are not designed to flag gradual buildup effects or subtle changes in how the body handles drugs over time. That is a systemic reality, not a personal failure. What matters is what you do from here. The fact that you have sat with this information today, that you are thinking about your medications in a new way and considering what questions to ask, that is the beginning of a different kind of engagement with your health. And that engagement, consistently applied over time, genuinely makes a difference. Not in a vague, inspirational sense, in a measurable, clinical, outcomes based sense. Patients who ask questions have better outcomes. That is not an opinion. It is what the data shows. So ask the questions, book the appointment, bring the list, start the conversation. Your health at 60 or 70 or beyond is still very much something you can positively influence. And that starts with simply deciding to pay closer attention.